Are you interested in some of the changes that are going to occur January 1, 2019, particularly as it relates to evaluation and management coding? So stick around. In this video, I'll share 2 hot topics. Hello, I'm Clarice Warner, the girl with the pearls, the founder and education director of the Professional Reimbursement Network, LLC, where coding education is key. And on this channel, we provide you with information, tips, and strategies on how to become a certified marketable medical coder. If you are new to our channel, welcome. Please feel free to hit the subscribe button and also hit the bell for notifications when we upload new content. Feel free to like and comment on our videos. We really appreciate that. Let's talk about what's going to happen in 2019. Particularly, let's talk about what's going to happen January 1, 2019, as it relates to CMS and some changes with evaluation and management services. The biggest thing that's happening in the world is that while they had proposed and while they had talked about making substantial changes in reducing the levels of services for evaluation and management and condensing them down into one, that's not going to happen. The work behind the scenes is still ongoing and they're still in discussions. However, they will not be making those changes. But they have made some substantial changes that, according to CMS, will reduce the administrative burden on providers. And one such change is that they will be allowing their ancillary staff members to complete some items that were traditionally only allowed to be documented by the provider. Those items, one such item is the chief complaint. Patient's chief complaint in history, particularly the history of present illness, will now be able to be documented by ancillary staff. The physician can pretty much document that they reviewed the information, but they do not have to re-enter any of that information. They can just make sure that there's documentation, and usually with the electronic health records, that information is documented, but they can just make sure that the workflow suggests that those items have been reviewed by the provider. And that actually applies to both new patients as well as established patients. Something specifically for established patients is that the provider does not have to re-record information about not only the patient's history, but also the patient's exam. So they can focus on anything that has changed from the previous visit or from one visit to the next visit. As far as the monitoring of this or the auditing of this, that's still in the air, and how that is going to be accomplished is still in the air, but we are anticipating that there will be some sort of guidance to provide auditors with the information that they need to validate that the documentation does support the level of services that are being billed. The other piece or other hot topic, and we talked about this in a previous video, and I'll link that video below, is from the proposed rule where they talked about potentially eliminating or reducing the fee for multiple service, or the 50% multiple service reduction on E&Ms and modifier 25. So what that meant was that if the patient came in and had an evaluation and management service, and they also had a minor procedure where they would add a modifier 25 to the E&M code, then they would reduce the lowest amount by 50%. So you wouldn't, usually adding the 25 modifier would indicate that it is a significant, separately identifiable evaluation and management service by the same physician or other qualified healthcare professional on the same day of the procedure or other service. And so adding that modifier would allow the payer to pay for both services, the evaluation and management service, as well as the procedure. Well, Medicare had proposed, or CMS had proposed, that that wasn't going to be the case, and they wanted to reduce one of those services by 50%. Well, based on all of the back and forth and the comments that they received, and how that this potential action may harm the Medicare beneficiaries more than it would be to reduce the burden, payment reduction burden, the level or the risk didn't outweigh the risk. So they still are in discussions on how to, what they call duplicative resource costs. So they're still looking to see how they may manage that. But right now they will not discount one of the services when an evaluation and management code is performed with a procedure and the modifier 25 is added. So those are the couple of things that I wanted to reach out to you real quick and talk to you about as it relates to some changes that will be coming down the pike January 1. Hopefully this was helpful. If it was helpful, please let me know in the comment section. If you were one of the people, and I know I talked about this before, asking people to comment. If you commented on the proposed rule, let me know. Put that information in the comment section. Also, if you think this is a good thing that they didn't change some of these things, or do you think this is a bad thing? Let me know that in the comment section as well. Let's have some dialogue. Again, if this information was valuable and helpful for you, make sure you hit the like button and share the information. And if you have not subscribed to our channel yet, what are you waiting for? Hit that subscribe button and be part of our community. I'm Clarice Warner, the girl with the pearls, the founder and education director of the Professional Reimbursement Network, LLC, where coding education is key, providing you with information, tips, and strategies on how to become a certified marketable medical coder. Reminding you to be safe, be kind, and don't wish for it, work for it. Until next time, take care.